Okay. Good morning, everybody, and welcome. Our speaker today is Dr. Norma Bosman. Norma is a clinical microbiologist with a vast experience, having previously worked at Charlotte Maxeke Johannesburg Academic Hospital under the National Health Laboratory Services for many years. She also lectured undergraduate and postgraduate medical students at the University of the Witwatersrand during this time. In 2018, she left the public sector and joined PathCare Vermaak in Gauteng, where she continues to be involved in ICU ward rounds and antimicrobial stewardship and infection prevention and control activities in various hospitals in Johannesburg and Pretoria. Dr. Bosman has a keen interest in novel technologies for the detection of antimicrobial resistance and is currently a member of the South African National Advisory Committee on Antimicrobial Susceptibility Testing. She also serves as the current chairperson for the South African Society for Clinical Microbiology. Thank you. We're very privileged to have you as part of our team and also to present to us.
Thank you. Good morning, everybody. Thank you for having me and thank you for inviting me. So just in continuation with our theme of going back to the basics of clinical microbiology, I thought today I would look at atypical bacteria pneumonia pathogens. I call them the forgotten enemy because that's exactly what they are. They are forgotten. If we don't look for them, we don't find them. And when they strike, they do hit hard. Just a quick introduction. So atypical community-acquired pneumonia represents more than 15% of all community-acquired pneumonias. And this term was initially used to describe viral community-acquired pneumonia. And also just another important thing is that these atypical pathogens causing pneumonia may also cause outbreaks of nursing and healthcare associated pneumonia, as well as hospital acquired pneumonia. However, this is rare. They're also often associated with systemic and extrapulmonary organ involvement. So this is quite important to remember. The most common pathogens that we're going to speak about today is Mycoplasmoides pneumoniae, formerly known as Mycoplasma pneumoniae, Chlamydia pneumonia, and Legionella species. Less commonly, we find Chlamydia psittaci, which causes psittacosis, and Coxiella bennettii. And then just to remember, pertaining to Mycoplasmoides pneumoniae and Chlamydia pneumoniae, the majority of these occur in young adults who are often ambulatory or in the outpatient setting. And of interest is that seroepidemiological studies show that 50 to 70% of adults have antibodies against Chlamydia pneumoniae. So we have all been exposed at least once in our lifetime. They're often asymptomatic, prolonged, or chronic infections that can last for months to years. And they've also been shown to precipitate asthma and COPD exacerbation. However, in contrast, Legionella species are an important cause of severe pneumonia. Just again, summary of clinical findings in general. So pneumonia from the Mycoplasmoides and Chlamydia, usually benign and self-limiting. However, a small number may develop into refractory and severe life-threatening pneumonia. In contrast, pneumonia caused by Legionella species is often a rapidly progressive severe pneumonia. It's got a high mortality of around 10%. This can increase up to 27% if your initial empiric antibiotic therapy is not adequate. Also to note, with Legionella species, you get your CRP, AST, ALT, LDH, and creatinine levels, which are significantly higher than the other pathogens. So this is a presumptive clinical diagnosis, and you require a high index of suspicion. So again, with these atypical bacterial pathogens, there are challenges in the laboratory setting. So we don't culture them using our standard methods. It's complex, it's time consuming. We also do not detect them on the gram stain. So the gram stain is our staining method that we use in the laboratory to distinguish between your gram positive and gram negative bacteria. We also have the urinary antigen test. However, the problem with this is that it only detects Legionella pneumophila serotype 1. Serology also, I don't need to tell you this, you require paired samples to document seroconversion. Appearance of IgM antibodies is usually late, and then it persists even after resolution of symptoms. IgG antibodies may be missed if your convalescent serum is collected too early. So you need at least 4 to 8 weeks after the illness to prove that this was indeed a pathogen. There's also cross-reactivity between your mycoplasmoides and chlamydia. Then another challenge with these pathogens is that your antimicrobial therapy is different. So your typical bacterial pathogens like your Klebsiella pneumoniae, classically they'll respond to beta-lactam antibiotics because they have a cell wall which is amenable to disruption by these agents. However, in contrast with your atypical bacterial pathogens, they do not have a cell wall. Some are intracellular and others are paracellular. So what this means is that you need antimicrobial agents that will interfere with intracellular protein synthesis enzymes and also have intracellular penetration into your alveolar macrophages. So here we're talking about your macrolides, tetracyclines, ketalides, and your fluoroquinolones. So just a quick recap into all of the pathogens individually. Back to when we had our microbiology lectures back in the day, I won't ask when that was. So looking at Legionella species, there's more than 39 species. However, Legionella pneumophila causes the most cases, 60 to 80%. And within the Legionella pneumophila species, you get a few serotypes. They're found in rivers, lakes, warm springs, domestic water supplies, fountains, air conditioning systems, swimming pools, and jacuzzis. So as you can imagine, transmission is via aerosols from any of these sources. Risk factors, usually in your immunocompromised patients, smokers, patients with comorbidities, and those who are older than 50. So clinical presentation, Legionnaire's disease, which is your severe form of pneumonia, which can also be a multi-system disease, which involves other systems. It's got a very high mortality, or you can be lucky and you get Pontiac fever, which is mild, resolving flu-like illness, and there is no significant mortality. So treatment of the pneumonia from Legionella species, levofloxacin, moxiflox, azithromycin. There's been no proven benefit of rifampicin or combination of azithromycin with a respiratory fluoroquinolone. Alternatives are your clarithromycin or erythromycin. However, just bear in mind that those are less well tolerated and they've been found to be less efficacious. Doxycycline is also a good alternative. Duration of therapy, 7 to 10 days in your immunocompetent patients, and you may have to extend that in your immunocompromised patients, up to 14 to 21 days. And prevention is maintenance of your air conditioning systems, and your hot water supplies must be consistently at a temperature of above 45 degrees. Next, we go to mycoplasmoides pneumoniae. Clinical setting. So this one has been found to cause infection mostly in children between the ages of 5 to 17, your young adults, and then older age groups over the age of 60. However, recently, since 2023, the CDC has been reporting an unusual increase in children aged 2 to 4 years. This has been seen since after the lull from COVID-19. And in the US, they're reporting an incident increase from 1% to up to 7%. So they are monitoring this. In terms of the transmission, it's respiratory droplets. So outbreaks have been described in schools and nursing homes. It's got a long incubation period of 1 to 4 weeks. Clinical presentation, like I said, mild symptoms, non-productive cough of up to 2 weeks. And usually these patients are described as having a walking pneumonia. So the chest X-ray findings are worse than how the patient actually seems. Severe disease with ARDS can also occur, and extrapulmonary complications have also been described, which would involve your skin, your CNS, GIT, and cardiovascular systems. Treatment, primary treatment is with doxycycline. This is preferred due to increasing macrolide resistance. So again, there's been reports of increasing macrolide resistance with Mycoplasmoides pneumoniae. It seems to be quite geographic. So mostly Asia, Europe, and the US. So in Asia, they are describing up to 98%, but this is very much concentrated in certain communities. And then in the US, it's anything between 13 and up to 27%. Unfortunately, we don't have any data for South Africa. Alternatives include azithromycin and levofloxacin. Then chlamydia pneumoniae, clinical presentation again, pneumonia, mild symptoms, fever, cough. This is often preceded by an upper respiratory tract infection and sore throat. Symptoms here are very difficult to distinguish from Mycoplasmoides pneumoniae, and often there's concomitant infection with other pathogens. Treatment, primary treatment here, doxycycline or azithromycin, and your alternatives would be levofloxacin or clarithromycin. Then the last one, chlamydia cytosine. So this one is infects birds. So it causes zoonotic infections in humans, and this is following exposure to birds or bird excrement. And people who are mostly at risk would be those who work in farms, laboratories, pet shops, poultry processing plants, veterinarian offices, zoos, and avian quarantine stations. Incubation period here is about 5 to 14 days, and transmission is via inhalation of dust, which contains dried bird droppings or respiratory secretions from infected birds. Incubation period here, 5 to 14 days. So prevention would be safe handling of bird and cleaning practices, and also your standard precautions. So wearing gloves, a mask. Clinical presentation, commonly upper respiratory tract infection with constitutional symptoms. Pneumonia, non-productive cough with chest X-ray changes. Extrapulmonary and systemic symptoms also quite common, usually a rash or splenomegaly. And this can complicate into a severe pneumonia, arthritis, encephalitis, endocarditis, myocarditis, etc. So primary treatment, doxycycline or azithromycin, and as an alternative, you can use clarithromycin. So just looking at our South African data. So unfortunately, the NICD does not conduct routine surveillance of our atypical bacterial pathogens. So the data that I have is mostly from the private sector laboratories. So this is a slide that I borrowed from Professor Nikki Kudals. So she puts together a monthly respiratory pathogen statistics, and this was for the month of January 2005. So if you look at the end there, so this is until the end of January. So I would think now we're sitting at about week 8 to 10, and she has gone back all the way to this time last year. So if we start with Legionella pneumophila, so if you look at the purple, as you can see, anything up to 2% of cases consistently. Mycoplasmoides pneumonia in yellow or orange. Again, anywhere up to 2.5%. And chlamydia pneumonia in green, also up to 3.5%. So we do see cases consistently. So this is across all of the PathCare laboratories in the country, and this is using molecular testing methods, using various respiratory assays. And unfortunately, this data is dependent on clinicians submitting the sample. So it's not representative of the general public. Another source of information in terms of South African data is the National Pathology Group. So National Pathology Group is made up of the three big laboratories, so Lancet, AMPAT, and PathCare. So this was data from the last quarter of 2024. And again, this is only private sector data. All right. So what I wanted to show here, it's in absolute numbers, unfortunately. So from October to December 2024, chlamydia pneumonia, we had a total of 234 cases. And mycoplasma pneumonia, we had 104 cases. And they reported only 14 cases of Legionella pneumophilus. I mean, you don't sound happy. So in terms of what is currently available for laboratory diagnostics, so detection by polymerase chain reaction is the best method from respiratory samples. So all three labs use very similar assays. So to save costs, you can ask for just a bacterial panel, which will include all of your atypical bacterial pathogens. It does not include Chlamydia psittaci. So if you are thinking of that pathogen, you have to tell us directly. On the right-hand side, we've got the pneumonia panel, which we use extensively in our patients in ICU who are admitted with severe pneumonia. As you can see there, it also covers the three main atypical bacterial pathogens and doesn't cover Chlamydia psittaci. Okay, so just to check that everyone has been paying attention, I'm going to present a case. So this was very interesting. This was a paper that I found. It was published from France, so a teaching hospital in France. So 3 cases of atypical pneumonia presented to the ER from the same family. So patient 1, the son, patient 2 was the mother, and patient 3 was the uncle. So they all came with fever, vomiting, and diarrhea. They had dyspnea and dry cough, and some of them required oxygen therapy. And they also reported that in the area, there was no viral epidemic that was going on. So the son lives with his mother. Uncle visits often. They own a stable with a single horse. They have dogs and some ducks. And they reported that all the animals were in good health. Any thoughts? Going once.
Wait 1 minute, I'm going to say it straight. Atypical pneumonia.
So A is patient 1, the son. B is patient 2, the mother. C is patient 3, the uncle.
Okay, that didn't see there a bit consolation. Look, that would probably go for mycoplasma pneumonia.
Okay, so let's see. So
No. How wrong am I?
no, you're not wrong at all. So just looking at the clinical characteristics. So in the table there, we'll start with patient 1. So patient 1, who is the son, a 51-year-old male patient. So he was admitted to the infectious diseases ward. He has obstructive sleep apnea, so he has a device. He's also got pulmonary sarcoidosis, and he also gave a history of neonatal hypoxemia. And then, as I mentioned, he presented with fever, dry cough, vomiting, diarrhea, and he also reported that in the last week, he had repetitive episodes of faintness. Looking at his blood work, so high CRP, no leukocytosis. However, he did have a hyponatremia, and liver function tests unremarkable, renal function deranged. And then in comparison, we look at patient 2. So this is mom, 78 years old. She was admitted to the pulmonology unit. She's a known patient with COPD asthma. Also presented similar symptoms. However, she required oxygen therapy. So she was given 6 liters per minute of oxygen. Looking at her blood results, high CRP, she's got a leukocytosis, hyponatremia, and she had deranged AST and ALT. Then the last patient 3 is the uncle who doesn't live with them but visits often. He was admitted to the infectious diseases ward, no medical history of note. And then over and above the symptoms that everyone else had, he also described having headaches, and he seemed to have more pronounced neurological symptoms. An LP was done on him, which was normal. Same, high CRP, normal cell count, hyponatremia, and normal liver functions. Any thoughts?
I think chlamydia.
Which one?
Chlamydia. Pneumonia. Chlamydia.
Right, so what was done? So mom had a bronchoscopy done, and then son and uncle had throat swabs that were taken. So all of them were negative on the multiplex PCR for Legionella pneumophilus, Chlamydia pneumoniae, and Mycoplasmoides pneumoniae. So son and uncle were started on levofloxacin because they had now excluded neurological infection in the uncle, and mom was started on ceftriaxone and a macrolide.
Chlamydia. The ducks.
So further history taking 4 days into hospital admission. So they all described having partaken in duck feathering 2 weeks before symptom onset. Don't ask me.
It's France.
And lo and behold, chlamydia cytosine was detected. So treatment was changed to doxycycline.
I'm thinking thrombocytopenia as well.
They can get, yeah. So then I just thought, let me look at our guidelines and just compare across the board in terms of what the recommendations are. So I looked at the South African treatment guidelines. They are a bit outdated. So last published in 2017, they don't mention much about the latest available diagnostic modalities. However, they do say that the urinary antigen test is not recommended. And then just looking in terms of, so across the board, outpatients, inpatients with non-severe pneumonia, you either use your beta-lactam agent or you use your respiratory fluoroquinolone. However, for inpatients with severe pneumonia, this is where you would add a macrolide. So at least we do cover these patients. And then going to the European guidelines. So this was quite interesting. This was made up of different specialists. So the European Respiratory Society, the European Society for Intensive Care Medicine, European Society for Clinical Microbiology and Infectious Diseases, and I forget what the last one stands for, but I think it was the Latin American Thoracic Society, if I'm not mistaken. So what they set out to do was to come up with guidelines for the management of severe community-acquired pneumonia. So what they were saying is everything is about community-acquired pneumonia, and we lump it together. So now let's talk about severe community-acquired pneumonia. So what they did is it was a total of about 18 individuals. So they looked at the literature, they looked at meta-analyses, and they came up with recommendations. So I just focused on the two that are relevant to us. So the first question is, in patients with severe community-acquired pneumonia, should rapid microbiologic techniques be added to current testing of blood and respiratory tract samples? And then their recommendation, which was low, and if you look on the left, there's your key there, and it was a conditional recommendation. So their recommendation is, if the technology is available, we suggest sending a lower respiratory tract sample, either sputum or endotracheal aspirate, for multiplex PCR testing whenever non-standard severe community-acquired pneumonia antibiotics are prescribed or considered. So I just went into the details in terms of why, they're not making a firm recommendation. So they do say, look, with the multiplex PCR assays, the advantage is you get a quick answer, so you don't have to wait for 48 to 72 hours for culture and susceptibility testing in order to either escalate or de-escalate antibiotics. However, they do worry about costs, and they do worry about these assays being abused. But I think I can say that here in our setting at Midstream Hospital, in the correct patient care setting, we have used these assays, and they've been very useful. And then secondly, when using initial empiric therapy for severe community-acquired pneumonia, should a macrolide or fluoroquinolone be used as part of combination therapy? So then their recommendation, again, low, which is conditional, they say we suggest addition of macrolides and not the fluoroquinolones. So here, they just said this was based on their literature review, where patients who were treated with a combination of a beta-lactam agent and a macrolide seemed to do better and had better outcomes. However, they do say that we need proper randomized controlled trials to compare head-to-head your beta-lactam with a macrolide combination versus your beta-lactam agent with a respiratory fluoroquinolone. Then I look at the American guidelines. So this was published in 2019. Just looking on the left-hand side, patients with, so this is hospitalized patients. And here across the board, whether it's severe or non-severe, they do recommend the addition of either a macrolide or a respiratory fluoroquinolone. Then if we look at outpatients, so here with the outpatients, if you don't have severe pneumonia, it's either or. So you either go for your beta-lactam agents or you go for your respiratory fluoroquinolones or macrolides. Whereas in your outpatients with comorbidities, so for example, alcoholism, diabetes, etc., here the recommendation is to add either a macrolide or use a monotherapy with your respiratory fluoroquinolones for treatment. That's it. Thank you.
Thank you so much. I think we needed to be reminded.
Couple of things. So I see they use a lot of doxycycline. So we probably don't use doxycycline as often.
Mm-hmm.
And then the other thing that I've seen in some scripts in our setting in ICU, I see a lot of levoflox plus azithromycin.
Yes. So I did mention that there is no data to say that.
So either
it's effective.
either one
It's
of
either or, not both.
Yes.
Yeah.
Okay.
Mm.
And you said the IV doxycycline is not
I don't think
available.
South Africa is registered doxycycline IV product.
Oral is
We've
like-
got the
Yeah,
only-
not oral, but I know overseas it's probably available. So depending on Section 21, we can probably try something, but but there's no registered IV doxycycline in South Africa that I'm aware of. They have oral.
It's not usually a very well tolerated like,
Yeah.
medication.
Mm.
And GI side of yeah. And if there's people online, if there's anyone that has a, let's see if there's anyone. I think we can. Don't open that, please. And then we can't actually see it now. Let's go and see hello, if there's anyone. Okay. I think we won this one. Very technologically
Do
challenged.
we have IV is azithromycin?
Yeah, but it's also not. So it's not prescribed often because of the when it's infused, causes a lot of burning. And so the
I think more for the ICU patients, the ones that get
Yeah.
intubated, that's really
so we
difficult.
do have IV azithromycin in the pharmacy. But as soon as you can switch to oral, it's usually recommended to switch to oral because of the infusion side effects like that.
Thank you very much, Norma. Appreciate.